Mycobacterium leprae. The other name for Mycobacterium leprae is Hansen's bacillus. It is one of the most important causative agent of leprosy. It is an ancient disease that remained as a social stigma for many years due to superstitious beliefs, and it will produce a characteristic deformities in the patients. Next one is the clinical manifestations and classification. Mostly the leprosy. In leprosy, it will involve mainly the cooler parts, but it is capable of affecting any tissue or organs, and it will cause bony deformities and disfigurements in untreated cases. And the incubation period of leprosy is very long. It is average of about 3 to 5 years. This can be explained due to longer generation of time, leprobacilli 12 to 13 days. In that lepromatous leprosy cases have longer incubation period than tuberculoid leprosy. Next one is the clinical classification of leprosy. First one is a Riddle-Joplin classification. Lepromatous leprosy, borderline lepromatous leprosy, borderline leprosy, borderline tuberculoid leprosy, and tuberculoid leprosy. Next one is the matrix classification. Lepromatous type, borderline, indeterminate type, tuberculoid type. Next one is the Indian classification. Lepromatous type, borderline, indeterminate type, pure neurotic type, and tuberculoid type. So leprosy is a bipolar disease. It has two classification, and the other varieties are borderline type. It is seen in patients possessing characteristic in between tuberculoid and lepromatous type. It will shift to either type of depending based on chemotherapy or alterations in the host resistance. Next one is the indeterminate type. It will denote early unstable cases in which one or two hypopigmented macules is seen and sensory impairment is definite. It is bacteriologically negative. And the other one is the pure neurotic type. It will show neural involvement but without any skin lesion. In pure neurotic involvement, it is bacteriologically negative. Next one is the differentiation between lepromatous leprosy and tuberculoid leprosy. The bacillary load of lepromatous leprosy is multibacillary, in which many macule lesions is seen. In tuberculoid bacillary, it is passibacillary, in which few macules are seen. The bacteriological index of lepromatous leprosy is 4 to 6 plus, and bacteriological index of tuberculoid leprosy is 0 to 1%. In lepromatous leprosy, the skin lesions is symmetrical and the margin is irregular. The lesions will appear as multiple nodules, which is known as lepromata, plaque xanthoma-like papules, and in lepromatous leprosy, leonine face is seen, and in eyebrow alopecia is seen. In tuberculoid leprosy, it is asymmetrical, margin is sharp, lesions will appear as hypopigmented, annular macules with elevated borders, tendency towards central is very clear. In lepromatous leprosy, nerve lesion will appear late, hyposthesia is a late sign. In tuberculoid leprosy, early anesthetic skin lesion will appear, in which thickened skin nerves is seen. The most common nerves involved in tuberculoid leprosy is ulnar nerve, followed by that post-auricular nerve involvement is there. In tuberculoid leprosy, nerve abscess is seen. It is most commonly seen in borderline tuberculoid type. Next one is a cell-mediated immunity, which is low in lepromatous leprosy, and in tuberculoid leprosy, cell-mediated immunity is normal. In lepromatous leprosy, the lepromin test and lymphocyte transformation test is negative. In tuberculoid leprosy, lepromin test and lymphocyte transformation test is positive. Complementary CD4-CD8 T cell ratio is 1:2 in lepromatous leprosy, and in tuberculoid leprosy, it is 2:1, in which it is normal. Humoral immunity is exaggerated in lepromatous leprosy. In tuberculoid leprosy, it is normal. In autoantibodies, lepromatous leprosy is elevated. In tuberculoid leprosy, autoantibodies is not seen. Venereal disease research laboratory tests biological false positive in lepromatous leprosy. In tuberculoid leprosy, it is negative. Next one, macrophages is foamy type in lepromatous leprosy. In tuberculoid leprosy, it is epithelial type. Langerhans giant cell is not seen in lepromatous leprosy. In tuberculoid leprosy, Langerhans giant cells is seen. Next one is the deformities of leprosy. In about 25% of untreated cases will develop deformities due to nerve injury that will lead to muscle weakness or paralysis. In disease process, mainly the facial deformities or loss of eyebrow is seen. Sometimes the infection or injury is seen, which will appear like a ulcer-like formation. Another common deformities are in face, leonine face is seen, sagging face, and in eyebrow, hair will loss, and corneal ulcers are seen. In hand, claw, hand, wrist drop is seen. In feet, foot drop, clawing of toes, inversion of foot, and plantar ulcers are seen in leprosy. Next one is the lepra reaction. Since leprosy is a chronic disease, several allergic type acute exacerbation will occur. So it is called as lepra reaction. It is of two types, 1 and 2. Lepra reaction type 1 is type 4 delayed hypersensitivity. Lepra reaction 2 is type 3, which is immune complex mediator. Lepra reaction type 1 is seen in borderline leprosy. Lepra reaction type 2 is seen in lepromatous variety and borderline leprosy. In lepra reaction type 1, inflammation of previous lesion and new skin lesion and neuritis will be seen. In lepra reaction 2, crops of painful erythematous papules which will become nodular. In lepra reaction type 1, it occurs before treatment and progresses towards lepromatous leprosy, which is a downgrading reaction. In lepra reaction 2, it occurs after following treatment of chemotherapy. In lepra reaction type 1, T helper cell response will predominate. In lepra reaction type 2, T helper cell it will predominate. In lepra reaction type 1, usually organs are not affected. In lepra reaction 2, eyes, testes, and kidney are affected. Next one is the epidemiology. Source of infection multibacillary, which include lepromatous leprosy and borderline leprosy. Cases are the most common source. Mode of transmission, mainly the transmission is seen through nasal droplet infection is the most common, and the contact transmission, breast milk, vertical mode, and through tattooing. Next one is the communicability. The communicable spread of leprosy is very high. Intimate and prolonged contact is necessary. Next one is a geographical distribution of leprosy. It is mainly confined in developing nations of Asia, Africa, Latin America, and Pacific. In India, it accounts for maximum cases globally. The prevalence rate in India is about 0.68 cases per 10,000 population in 2012. About 32 states or union territory have already achieved the level of leprosy elimination. Prevalence rate is less than 1 case per 10,000 population. Chhattisgarh and Dadra and Nagar Haveli are the only state or union territory which it remains above the level of leprosy elimination. So in borderline, Bihar lies in the borderline. Next one is a laboratory diagnosis of leprosy. First one is a smear microscopy. It is done to demonstrate acid-fast bacilli in the lesions. Totally in leprosy, for smear microscopic examination, 6 samples are collected, 4 from the skin, forehead, cheek, chin, and buttock. earlobe and nasal mucosa. The edge of the lesion is most commonly the preferred site for leprosy examination. Split skin smear is the technique followed to collect the skin and earlobe specimens. Nasal specimens are collected by nasal blow and nasal scarping. Biopsy from thickened nerves and nodular lesions may be necessary in some cases. In leprosy, the acid fast staining technique is done by Sale-Nelson technique by using 5% sulfuric acid. Next one is the appearance. It will arrange like singly or in groups, and sometimes it will bound together by lipid-like substance. The glia to form globi, which is known as cigar bundle appearance. The globi will present inside the foamy macrophages, which is known as lepra cells or foamy cells. Live bacilli will be uniformly stained with parallel sides and round ends, and length is 5 times than the width. Dead bacilli are less uniformly stained and it will have fragmented and granular appearance. Next one is a grading of smear is done by bacteriological index. Bacteriological index, it is based on the total number of bacilli which is live and dead, which is seen in oil immersion field. Next one is the morphological index, percentage of uniformly stained bacilli out of total number of bacilli counted. It is a better marker to monitor the treatment response. Next one is a solid fragmented granular rod percentage is used. Another method is the mouse food pad cultivation. Mycobacteria leprae is not cultivable, so either in artificial culture media or in tissue culture it is cultured. The only certain way to culture is by inoculating the specimens into 9-banded armadillo and food pad of mice. Next one is the antibody detection. Fluorescent leprosy antibody absorption test is done. ELISA detecting immunoglobulin M antibodies to phenolic glycolipid 1 antigen of Mycobacterium leprae. Next one is the test for detecting lepromin test. Lepromin test will demonstrate the delayed hypersensitivity reaction and index in cell-mediated immunity against the lepra antigen. The procedure for lepromin test is 0.1 ml of lepromin antigen is given intradermally in the forearm and reading is taken in twice, one at 48 hours and the other one at 21 days. Early reading, it is otherwise known as Fernandson reaction, which will appear within 48 hours, in which the induration and erythema is seen, which is greater than 10 diameter, which will indicate the delayed hypersensitivity reaction and hence past exposure to lepra bacilli. Does not indicate active infection. Next one is a late reading. It is otherwise known as Mitsuda reaction. It will appear at 21 days. Nodule of greater than 5 size will be formed at the site of inoculation. At later stage, it will ulcer. It indicates the patient's cell-mediated immunity is intact. Next one is the uses of lepromin test. The late reaction measures the cell-mediated immunity. It is used for classifying lesions of leprosy. In tuberculoid leprosy patients with intact CMI, the test is strongly positive. In lepromatous leprosy, the test is negative, indicating low cell-mediated immunity. Next one is accessing prognosis. Intact cell-mediated immunity in tuberculoid leprosy patients, it will indicate good prognosis. Accessing resistance to leprosy in individuals. Leprosy negative patients are higher risk of developing multibacillary leprosy than lepromin positive persons. Next one is the prevention of leprosy. Active case finding and effective treatment is the most important method. Another prevention is the BCG vaccine. Various trials are going on. Hospitalized patients need not to be isolated because transmission requires prolonged contact. Next one is the leprosy elimination. National Leprosy Eradication Program in India aims at two major components. One is elimination of leprosy, which is already achieved in India, except in Chhattisgarh, Dadra and Nagar Haveli. Decentralize the services through central healthcare system are the two important aims. Another one is that though India has achieved the elimination level, still India accounts for the highest number of leprosy cases worldwide. The long-term aim is to eradicate leprosy. Eradication is possible because it is difficult because of long and variable incubation period, disputed mode of transmission, more subclinical cases, low immunity in patients with lepromatous leprosy, absence of effective vaccine, bacterial resistance, complicated spectrum of disease, poor patient complaints because of longer duration of treatment, and due to social issues, the eradication is difficult. Next one is the National Institutes of Leprosy or National Institute of Leprosy and Other Mycobacterial Diseases, Agra. Central Leprosy Training and Research Institute, Chengalpattu, Tamilnadu.